Welcome to this Step 3 review on management of the human immunodeficiency virus, brought to you by Roadmap to Residency. This topic appears on your exam again and again, and it is one of the most predictable topics you will face. The stems follow a small number of patterns, and once you recognize the pattern, the answer identifies itself. Our goal is not to reteach the immunology. It is to show you how these stems are built and how to attack them. Work through your question bank alongside this video. Let us get started. This topic breaks into 4 archetypes, and almost every question you see will be one of them. Screening and diagnosis, where a number decides which test you order. Treatment initiation, which has the single most reliable rule on the exam. Prophylaxis, which is pure pattern matching to a threshold. And prevention counseling, where the writers plant traps designed to make you judge the patient. We will walk through practice questions for each and explain why every choice is right or wrong. This video assumes baseline knowledge from your review resources. We are here to sharpen how you take the test. Our first archetype is screening and diagnosis, and the key skill is finding the number. These stems bury one detail that decides everything, and it is almost always a number. The age of the patient, the count of the helper T cells, or the amount of virus in the blood. Circle it before you read the choices. Everyone from their teenage years to their mid-60s gets tested at least once regardless of risk, and higher-risk patients get tested more often. Then know which test comes when. The writers love the patient infected within the last few weeks because antibody-based testing has a window period and can read falsely negative early. So when the stem stresses a very recent exposure with fever, sore throat, and rash, they are pointing you toward the test that detects the virus itself rather than the antibody. Archetype 2 is treatment initiation, and this is the highest yield rule on the entire topic. Everyone diagnosed starts antiretroviral therapy, and they start immediately. It does not matter what the count is. It does not matter that the patient feels perfectly well. New diagnosis plus next best step means treatment now. Watch for the delay trap, because it appears in nearly every one of these questions. The classic wrong answer offers to wait. Wait until the count drops below a threshold. Wait until symptoms appear. Repeat the count in 3 months and decide then. All of these are outdated and all are wrong on your exam. There is one true exception, a specific fungal infection of the lining of the brain, where starting too quickly can worsen inflammation. Outside of that, start now. Archetype 3 covers prophylaxis and prevention. Prophylaxis stems are pure pattern matching, and the count is the trigger. Below 200, cover the fungal pneumonia. Below 50, add coverage for the disseminated mycobacterial infection on top. Read the count first, then find the choice that matches that threshold. Prevention counseling works differently. When a patient without the infection describes ongoing risk, the exam wants you to offer pre-exposure prevention medication rather than counsel abstinence or advise condoms. Confirm the patient is truly negative, check kidney function, then plan repeat testing every 3 months. And beware the judgmental distractor. Choices that scold the patient, refuse the request, or make prevention conditional on behavior change are always wrong. Let us work through our first practice question. A 32-year-old man is seen in clinic after testing positive on a combined antigen and antibody test, confirmed by a second test. He feels well and has no complaints. His helper T cell count is 640, a healthy count, and his viral load is measurable. His examination is unremarkable. The question asks for the most appropriate next step. Notice what the stem emphasizes. He feels fine and his count is high. Ask yourself why the writer bothered to tell you that. First, spot the pattern. The stem hands you a confirmed new diagnosis in a patient who feels completely well and whose count is reassuringly high. That healthy count and that well-feeling patient are bait. They exist to tempt you toward waiting. Second, apply the rule. Everyone diagnosed starts therapy immediately, regardless of count and regardless of symptoms. Early treatment improves survival and prevents transmission to his partners. Third, eliminate. Repeating the count in 3 months is the outdated approach and delays treatment he needs today. Waiting for the count to drop below 350 is the same trap wearing a different number. Prophylaxis against fungal pneumonia is not indicated at a count of 640. The answer is to start antiretroviral therapy now. The high count did not change the answer at all. Our second practice question tests prophylaxis pattern matching. A 41-year-old woman with a known diagnosis has not taken her medications in over 2 years. She reports a month of fevers, night sweats, and weight loss. Her helper T cell count returns at 30. She has no cough, no headache, and no visual complaints. She is restarting antiretroviral therapy, and the question asks what else you should do. Find the number and match it against every threshold you know. Notice how low that count is and think about how many obligations it creates. Read the count first, because the count of 30 is the entire question. Every threshold has been crossed. Below 200, you owe her coverage for the fungal pneumonia. Below 50, you owe her the disseminated mycobacterial coverage as well. One number, two separate obligations, and that is the whole point. Trimethoprim with sulfamethoxazole alone leaves the mycobacterial gap wide open at a count of 30. Azithromycin alone abandons the fungal pneumonia coverage she has needed since her count fell below 200. And no prophylaxis ignores the window before her immune system recovers, precisely when she is most vulnerable. The answer is both drugs together. When you see a very low count, ask how many thresholds you just crossed, not just one. Prevention counseling stems have a different flavor, and people lose points here for the wrong reasons. First, recognize the setup. The stem describes a patient without the infection who has ongoing risk, and it often includes a detail designed to make you uncomfortable, such as multiple partners or inconsistent condom use. That discomfort is the trap. The correct answer offers prevention medication without judgment. Second, do the two checks. Document that the patient is truly negative, because starting prevention in someone already infected risks resistance. And check kidney function. Then plan repeat testing every 3 months. If a choice skips confirming negative status before starting, it is wrong. Our third practice question is a prevention counseling stem. A 26-year-old man comes to the clinic and asks about a medication he can take to prevent infection. He has multiple partners and uses condoms inconsistently. He feels well. His testing today is negative and his kidney function is normal. The question asks for the most appropriate next step. Notice the stem has already handed you both checks, and notice the details about his partners and condom use. Ask whether those should change your management or whether they are there to provoke a reaction. Both checks are already done for you. He asked for prevention, he is confirmed negative today, and his kidney function is normal. He has ongoing risk and he is asking for help. Start the medication and plan repeat testing every 3 months. Now the key distinction, advising condoms instead, is the substitution trap, because counseling is good, but it is not a replacement for a far more effective medication. Making the medication conditional on 6 months of demonstrated safer behavior is the judgmental distractor, and that flavor of answer is always wrong. Deferring and testing in a year leaves him unprotected for a year. Every wrong choice withholds effective prevention from a patient who asked for it. Here is the pearl that ties this topic together. The number drives the answer. Scan the stem for the helper T cell count before you read a single choice. If there is no count, look for the timing of the exposure or the age of the patient, because one of those 3 numbers is almost always the hinge. Then match the number to the threshold. Below 200, cover the fungal pneumonia. Below 50, add the mycobacterial coverage. Recently exposed with a flu-like illness, test for the virus itself rather than the antibody. Newly diagnosed at any count. Start therapy now. That wraps up our review. Find the number in the stem first, because it is almost always the hinge. Everyone diagnosed starts therapy immediately, no matter the count and no matter how well they feel. Below 200 means fungal pneumonia coverage, and below 50 means you add the mycobacterial coverage. And when a patient asks for prevention, offer it without judgment after confirming they are negative and checking kidney function. Drill these in your question bank under timed conditions and read every explanation, even on the ones you got right. Any major review resource covers this in its infectious disease chapter. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If this video helped, please like and subscribe so you do not miss our next session. Good luck on your exam.